So please welcome Dr. Loomis.
Thank you. Thanks a lot. Can everybody hear me okay? Yes. Okay, good. That's good. Well, I am a licensed psychologist, and I specialize in an area called behavioral sleep medicine, which is a very small subspecialty within sleep medicine. And I really appreciate being here today and talking to the Wisconsin sleep professionals, and especially I love talking about this particular topic, cognitive behavioral therapy for insomnia, which I'll call CBTI for short. So I did put down my contact information. Feel free to contact me if you do have any questions or if you need any resources. I'd be happy to, communicate with you and get you what you need. I thought about changing this little cartoon graph because many of you have probably seen it before, but it just seems so appropriate at the very end of the end of the conference here in the afternoon after you've been to so many presentations. So I wanted to keep that in. But I will talk a little bit about the outline for today, what we'll be talking about. I wanted to talk a little bit about the diagnosis of insomnia and the history of CBTI. I wanted to talk a little bit about the rationale for CBTI. And this is especially important because with this treatment, patients often really need the rationale because some of the things that they're asked to do are very difficult and somewhat counterintuitive too. So if you think about, somebody with insomnia and telling them, well, we're going to have you spend less time in bed, that is pretty hard to take. So being able to really talk about the rationale can be very important with them. We'll talk a little bit about the components of CBTI, the research on it, and then we'll have a little bit of a discussion of sleep hygiene because I think, in the absence of CBTI, sleep hygiene is often what is used and often is very helpful for patients. And then we'll talk a little bit about where to refer your patients for CBTI. I did want to add a little bit about the information that patients get from the media and from their social media and from magazines out there, because the information that they get can be really confusing and that doesn't always correspond to the messages and the theory that we want to communicate with them. So let's talk a little bit about insomnia disorder. The criteria is really pretty straightforward, right? And this is the DSM, which is our kind of Bible of mental health conditions. It's the Diagnostic and Statistical Manual. And the criteria is that basically there's a difficulty falling asleep, difficulty staying asleep, and waking up too early. And we usually use the 30-minute criteria for that. So if it's longer than 30 minutes to fall asleep, if a person is awake more than 30 minutes in the night, that meets the criteria. And that occurs at least 3 nights per week, and it occurs at least for 3 months. It's been going on. It's also associated with daytime impairment or distress, so you kind of need that component to get the diagnosis of insomnia. And the poor sleep occurs despite adequate opportunity. And, this can be kind of confusing for patients because when you look at some of the articles and things out there, sometimes the message is, well, you don't sleep well, you've got a sleep problem, you really need to get more sleep because sleep is really important. And keep in mind, these are people who are giving themselves a lot of opportunity for sleep and they're not able to sleep. So sometimes for patients, they'll get confused between sleep deprivation, people who just aren't getting enough sleep and need more sleep, and insomnia, which is kind of a different condition. We use the Insomnia Severity Index a lot, and it's used for research as well. It's a really nice self-report measure. It might be interesting for your sleep apnea patients. to look at their level of insomnia, because it may give you good information about how they're going to respond to CPAP. And I can give that to you if you want. You can always email me about it. For the treatment, we always use sleep log data, and we pretty much use it throughout the treatment. We use it for assessment, and then we use it to make judgments about where we want to go for the treatment and where we want to go for changing a person's sleep schedule. It can be really helpful. Sometimes with the treatment, patients get more sleepy, and so they're saying, oh, this isn't working, I'm more sleepy. So it's helpful to go back to the sleep log data and say, oh, look at how your sleep efficiency is increasing. You are making some progress here. So the sleep log can be really helpful. I did want to mention just about the next day consequences for insomnia, which is part of that diagnosis. If you think about sleep apnea patients, you'll see that excessive daytime sleepiness, right? They'll be sleepy, they'll fall asleep when they're driving or when they're reading or when they're working. This is a little bit of a different presentation, and the reason why is that insomnia is a condition of hyperarousal. And so there's hyperarousal at night, but also during the daytime as well. And how the patients experience it is kind of like a tired but wired feeling. And so the worst thing that people experience, I think the most distressing thing, is when people are so fatigued, they're exhausted, and they try to take a nap and they can't fall asleep for the nap. And fortunately, this is something that can change during the treatment, is things are headed in the right direction if people say, oh, I was actually able to fall asleep for a nap. But you'll see things like fatigue is the most common daytime consequence of insomnia, but you'll also see people talking about that they're just not thinking as well, they're foggy, they are irritable, they're crabby, and they're just not as motivated. So maybe they're not exercising and doing other things that they're interested in doing or used to do. There has been a real shift in insomnia in the diagnosis of it. When I first started, I was not in sleep, I was more in general psychotherapy. And if somebody had insomnia, we would send them to the psychiatrist, they were usually working with, and we would say, well, you need to really get that depression or anxiety under control. So the idea was that insomnia was always a symptom of some other disorder, whether it be a mental disorder, a sleep disorder, or a medical problem. And we have really changed our thinking so that we're now looking at insomnia as a separate disorder and even an independent disorder, or there are kind of complex relationships. Let's say with depression, yes, it may be that depression causes insomnia. Insomnia is a symptom of it, but it could also be, we know now, that depression or that insomnia can cause depression as well. And so it's a different way of thinking about things. Sorry, let me just look at this. I did want to show this slide because this is a study that was done on people who had had treatment for depression. And it went pretty well. Their depression was much better. But as you can see, then they looked at what are the residual symptoms that were occurring after depression treatment. And as you can see, sleep, whether it was above the threshold sleep problems, so kind of significant sleep problems, or if it was more subtle or less severe sleep problems, about 60% of the people still had sleep problems. And they've done this with PTSD and other disorders, and they found that just treating that primary, if it was considered the primary issue of depression, wasn't enough to really take care of the insomnia. So we know now that with depression, for example, often we treat the depression, but we treat the insomnia as well. And so in terms of the criteria, we looked at the DSM-5 a little bit earlier, where it was insomnia disorder. The one before that was DSM-4, and they had this primary, secondary distinction. So primary insomnia, you can see A and B was about the same as what I showed you before, the criteria for insomnia. But then you've got this C, D, and E, right? And those are kind of rule outs, right? So you're taking out the people who have sleep disorders, who have psychiatric disorders, who have medical disorders, and so then people kind of go into that secondary. Their insomnia is secondary to something else. So in the newest DSM, those were taken out, and we just have one insomnia disorder. So I'll talk very briefly about the circadian rhythm timing. I'll skip over this a little bit, but with CBTI, we really want to consider what their circadian rhythm timing is, if they're more of a night owl, if they're more of a morning lark, because of course it can really influence treatment. If you have somebody who says, oh, I can't fall asleep, it could be insomnia, right? But it could also be a delayed circadian rhythm, especially if they're trying to go to bed a lot earlier than what their body wants them to go to bed. So if they're going to bed at 10 and they can't fall asleep for 2 hours, it could be that if they went to bed at 3 a.m., then they would be able to fall asleep just fine and stay asleep, and there's no insomnia there. So we do really look at that in terms of our treatment. So we have the night owls, and then we also have the morning larks as well. With the night owls, the vulnerability for insomnia is at night. It's difficult to fall asleep. For the morning larks, and as you get older, you know, falling asleep in front of the TV, our circadian rhythm shifts earlier, so that we're going to bed earlier, waking up earlier. And there, the vulnerability is in the morning. So people have difficulty with waking up way earlier than what they want to. And then there can be kind of a psychological thing there too, where people are saying, oh no, I woke up at 4 a.m., this is really bad. And then maybe the next morning, they wake up at 7 a.m. and they're really like so happy about that. But it's always inconsistent. So it creates this kind of a mental focus on the situation, some anxiety about it, some judgment, negative judgments about it, that really increase that sense of hyperarousal there. Now, what I found is the most helpful thing for patients is if they're able to kind of own their circadian rhythm, if they're able to learn about the circadian rhythm, which they might not know anything about it, and then be able to say, oh yeah, that is, you know, that's me, I'm more of a night owl, or I'm more of a morning lark. What we find is that the treatment just goes a lot better. So for example, for night owls, often the daytime part of their sleep gets really interrupted. If you have, say, an elderly woman and she's a night owl, but her adult children really want her to get going in the morning, right? And so they'll call her and they'll arrange breakfast to go to and everything. But when the person is able to say, hey, this is my schedule, I'm a night owl, then we're able to get that time that they are sleeping to be much more peaceful and less interrupted. All the spam calls aren't coming in and notifications, and their family isn't calling. So I think for patients to really understand their circadian rhythm is really helpful in the process. So I wanted to talk a little bit about the history of CBTI. And CBTI really comes from CBT, cognitive behavioral therapy. And Aaron Beck is kind of the founder of cognitive behavioral therapy. He worked with people who are depressed. And what he found out, and it's interesting, back when he was starting, it was during the time of psychoanalysis. Remember from your psychology class, Freudian and Jungian and interpretations from, about childhood, and the patient was often on a couch and kind of free associating, and there wasn't a lot of feedback, maybe some interpretations from the therapist. So that's kind of when he started this. And what he said was that people who are depressed have a negative view of the self, the world, and the future, and that this view is distorted in some way. And so the focus was on behavioral, cognitive behavioral. There was a behavioral focus, right? Let's say somebody is depressed and they can't get out of bed. So first of all, you'd work with them behaviorally to get them out of bed and have some success with that. And then to work on the cognitive part. So maybe if they think, oh, I'm a loser, I can't even get out of bed, they're getting out of bed more quickly or earlier. And then they're also saying, well, maybe it's not that I'm a loser. Maybe I'm just, I was kind of bowled over by depression, and I'm really not such a bad or incompetent person. And what they found is that this treatment was really very effective. Now, there are some things about the treatment that are about the process of the treatment, right? So if you look at the process, the therapist and the patient form a collaborative relationship. It's a therapeutic alliance in a sense, and it's something where ideally, when it's done well, the therapist kind of gives Socratic questioning to help the patient come to some of the conclusions. And, as you can imagine, if a patient comes to the conclusion of, oh, I think I need to set an alarm for 5 a.m., that's going to be a lot better than if you're coming to that conclusion and telling them about it. So that's kind of the idea of how it works with that therapeutic alliance that's established. And the other thing is that it's a pretty active and directive treatment, and that there's empirical research support for it, which there was less of for that psychoanalytic therapy. Now, these are book covers of CBT applied to all sorts of different disorders, and it really became the kind of the standard treatment in mental health. One thing to keep in mind, because this can be very confusing for patients, is that some patients get the idea, well, I need CBT. And so they look for a therapist, for CBT. And it might not be the case that a CBT therapist would have that expertise for insomnia. And so they might end up kind of in the wrong treatment. So just like I wouldn't be able to do CBT for PTSD, I would need a lot of extra training and probably some supervision. CBT therapists aren't able to just step right in and do the CBTI as well. So sometimes that needs clarification for patients. These are 2 manuals for CBTI. I would really recommend them. They're very good. The blue one here is the one by Michael Perlis and colleagues. It's really a classic, and most people in my field use this. It outlines every single session that you would have with a patient, and it's a very good place to start if you're doing this work. One thing I would mention about it is the treatment is multi-component. And so it's usually, I would say, 6 to 8 sessions. I always tell patients, it varies. It depends upon the individual, how many sessions it is. But some people say, I don't know about this whole CBTI. Let me go for a couple sessions and then I'll see if it's working. And usually that is not such a good approach. Usually it's better if people are really able to commit to the full treatment, because it does involve a certain amount of, I say to patients, training the brain. That's not going to happen right away. the treatment is based on the model of Arthur Spielman. It's the 3P model. It's the idea that there's not just one thing that causes insomnia. There are a number of factors. And the first set of factors are background factors before a person even gets insomnia. There might be personality factors or circadian rhythm factors, or there might be a genetic history of insomnia. There might be a history of abuse that the person has, so that there's already hyperarousal there around the nighttime. Then at some point the insomnia starts, and the example that's kind of funny would be somebody who has a new baby, and they're like, oh, I'm not sleeping at all, and that's where my sleep problem started. But then, however, maybe 18 years later, that child is all grown up and is sleeping just fine, but that parent still has sleep problems. And that's when you look at what are the maintaining factors, what are the things that are keeping the sleep problem going. And those perpetuating or maintaining factors are really the things that we want to cross out and eliminate for the person to sleep better. I'll mention some of the perpetuating factors, and these are kind of the main ones. First of all, there are disturbance to the circadian rhythm and disturbances to the sleep drive. And as you know, these are the two physiological mechanisms that put us to sleep and keep us asleep. And those, through insomnia, can get weakened and kind of need strengthening, and that's the basis of the treatment. One way that this kind of gets out of whack is that if you think of a person with insomnia, let's say they give themselves 8 hours. That's their window of opportunity. That's their time in bed. They are not sleeping that long, right? If you have insomnia, you're not sleeping that whole window. So you're actually generating, let's say you're generating 6 out of that 8 hours. And there's a mismatch there. And over time, that mismatch becomes a perpetuating factor. Part of the reason it does is it might affect the circadian rhythm. There might be a really inconsistent wake-up time as people are, extending out their window to try to cope with the insomnia. And that can weaken the circadian rhythm. It could be if they're giving themselves 8 hours, they're going to bed a lot earlier than what their body indicates that they should, and they're not able to build up that homeostatic sleep drive enough so that they're able to fall asleep. Also, if you think about, sleep efficiency is 60% or 70%, there is a lot of time that person will be awake, and then that gives rise to this hyperarousal that can be there. And so this conditioned arousal, right, the hyperarousal occurs with the bed and the bedtime. People sometimes say, oh, I'm out in the living room and I can get really sleepy and I'm so excited about that. But then I go into my bedroom and then all of a sudden I'm thinking and I'm feeling restless. And that's an example of that hyperarousal that's conditioned to a particular time and place, really. Other things that are perpetuating factors are people are putting more effort into sleeping, they're worrying about not sleeping, and then of course there are sleep hygiene factors as well. So if there's a strong sleep drive, if there's a good strong circadian rhythm, and if there's low arousal, then that would give you good sleep. Then, if you have a weak sleep drive and you have some circadian rhythm dysregulation and you have high arousal, that would lead to poor sleep. Now, think about what people often read about and what your patients might tell you about this. They might say, well, if I'm not properly putting the day to rest, that might cause, or if I do put the day to rest properly and I can really wind down, then that would equal good sleep. And if I'm able to clear out my mind, that would equal good sleep. And if I'm able to just be nice and relaxed, that would create good sleep. So that's kind of the way often patients are approaching insomnia, but it's not often the most helpful way, because when they're thinking that way, it's all on them. The burden is all on them, right? They have to relax, they have to wind down, they have to do this and that. And that's not necessarily helpful to get the circadian rhythm and the sleep drive to be working optimally. So that can increase effort and it can increase anxiety. Now, all of those things, being more relaxed, winding down, can be very helpful too. But with this model, it's not the kind of the active component, I guess, of helping people to sleep better. There are some core components of the treatment: sleep restriction and stimulus control. Really, for CBTI to be most effective, those are usually included. And then there are other components. There's cognitive therapy, there's relaxation, there's looking at sleep hygiene as well. Sleep restriction is, remember we talked about the mismatch between the window of opportunity and what the person is sleeping, and there can be low sleep efficiency. And what do patients think? They think, well, I need to sleep more, I need more sleep. And so it helps initially to tell them, well, we're going to give up on that whole idea of getting more sleep. Right now, we just really want to work on getting quality sleep. So the goal really is to increase sleep efficiency, not necessarily add more time initially, because with insomnia, you just can't do that, right? You can't just say, oh, sleep longer or sleep more. So this cartoon, I really like it because it's what I think all the time when I see a patient's sleep log. Oh, no wonder you have insomnia. You're lying there awake all night. And so what we do is we use the sleep log to get an average time that they're in bed, let's say 8 hours. And then we're looking at how much are they actually sleeping on average, 6 hours, let's say. And then we're bringing in that schedule so that they've got 6 hours opportunity to sleep now, or 6.5. Sometimes we add in half an hour. And then we have them do that. We usually say, oh, it's not going to be helpful in the first week. You might not notice a difference. And then we kind of titrate it. So if sleep efficiency is above 90%, then we can gradually add in a little bit of sleep time. If the sleep efficiency is really low, then we might readjust it and bring it in a little bit more. So it's a process of going through that usually takes about, I would say, 6 weeks or so to really get to the point where the sleep drive is higher. So the sleep drive is higher, the circadian rhythm is stronger, and the sleep efficiency is higher as well. There are some contraindications if a person has bipolar disorder, if a person has epilepsy, if a person has hypersomnia or really strong anxiety. You have to modify this sometimes and not do that treatment. Stimulus control is an intervention that can be effective on its own, but it's especially effective if you combine it with sleep restriction. And that is the idea of getting out of bed if you're not sleeping. So what you're doing is you're limiting the associations that the brain has. So if you're sleeping really well, right, your bed is associated with sleep. If you're not sleeping well and if you're awake, the bed is associated with sleep a little bit, right? But it's also associated with tossing and turning, thinking about the next day, thinking about the previous day, looking at the clock, all of those different things. So what you're doing with stimulus control, saying get out of bed if you're not sleeping, is you're limiting the associations there and creating a stronger connection between the bed and sleep, which then reduces the hyperarousal too. Now, this is another thing. What do you read in women's magazines and men's magazines? They say, oh, if you're not sleeping, just get out of bed, right? And the problem with that is that it can be really hard to do, and there are a number of different ways that it can be not as effective. And so some of those ways are when the patients expect it to work like a sleeping pill immediately, and they'll say, well, I tried that once, I got out of bed, and I didn't, I was up for hours reading, and that didn't help at all. They're thinking of it like it would work like a sleeping pill, when it really doesn't. Remember, the purpose of it, the rationale, is that over time you're associating the bed with sleep. People might, because they're hoping that it's going to work and they're going to be able to fall asleep in the short run, they might sit in the dark, or they might do something really boring. Some people, it's kind of funny, they say, oh, I read the Bible because it's really boring. And so they're, the problem with that is what happens. It increases the anxiety, it increases the focus on is the person feeling alert, and that's a bad thing, and then so it just creates a lot of anxiety. People can watch the clock and say, well, I've been up for a half an hour, that's long enough, I'm gonna go back to bed, but maybe they're not really ready for bed yet. So then it's less effective because they're going back to bed when they're still feeling awake. Sometimes people worry about waking their family members and they don't get out of bed for that reason. Sometimes they do work or they eat in the middle of the night, or they're on the computer. Although I would say the more anxious a person is about their sleep, the more you can use things. Like sometimes we say, hey, watch TV, and it actually helps them because it's such a good distraction for their anxiety. So it's doing something that kind of takes your mind off of being awake at night. Sometimes the belief sleep is precious. Oh, I can't get out of bed. I just couldn't do it because I thought maybe I really would fall asleep. The eternal optimist there. Often people are thinking that it's going to happen and they don't get out of bed. And then, of course, the patients that I meet with, maybe they've had insomnia for 5 years, and they say, yeah, but, well, I know I should be getting out of bed. And so for all those nights, right, whatever the math turns out to be for 5 years of insomnia, they're probably thinking to themselves, well, oh, I should be getting out of bed, and I'm not. Or maybe they'll say, oh, tonight I did get out of bed. Maybe 1 out of 7 nights, or once every 2 weeks I got out of bed. But it doesn't really help to train the brain to associate the bed with sleep, so it's not as effective. Of course, sleeping later in the morning to compensate, then the sleep drive doesn't have a chance to build up. In the beginning, when I started with this work, I focused on the first bullet point here in terms of cognitive therapy, right? People with insomnia often have these catastrophic thoughts in the middle of the night. They're thinking, oh no, I'm not going to function at work tomorrow, or I'm going to make a mistake, or I'm going to really yell at my spouse, and that's not going to be good. So we do address that, and with cognitive therapy, right, is this belief distorted? Do we need to change it and help a person to think kind of more realistically or more accurately about the situation? But now I talk to patients more about just the insomnia mind is what I call it. And there are a number of different things the mind does with insomnia. One is why thoughts. People who say they're thinking about why am I not sleeping, and they're really focused on that. And the problem is they can't come up with an answer, and then the frustration really goes up. So they say, well, it's dark, it's quiet, I'm here in bed, nothing stressful happened today, and so why am I not sleeping? And that can just increase that hyperarousal. Monitoring time in the night is part of the insomnia mind. Excessive decision making, and this can be related to what to do at night. Okay, I'm awake, what should I do? Well, I don't really want to get out of bed, but maybe I should do a relaxation or a breathing exercise, or maybe I should turn on the TV or look at my phone. And so there can be a lot of thought about that. There can also be a lot of thought about sleep medications. And the sleep log is great to be able to see what medications they're taking and at what dosage. And so you can see sometimes if maybe they have a melatonin 3 milligrams and then 5 milligrams and then other things too. And it's a decision-making process, like what should I take tonight? Oh, am I really alert? Maybe I'm not going to sleep tonight. So maybe I really need to take more stuff. And so what we try to do with the sleep medications is put it on automatic pilot. I mean, I'm not an MD, so I defer the whole sleep medication issue, but we do, I do sometimes work with the physicians, and psychologically speaking, what we want to do is put it on automatic pilot where people aren't thinking about medications and making decisions nightly about what to take. There can be monitoring for alertness in the night. If people feel alert, they say, oh no, I'm alert, that means I'm never going to get back to sleep. Now that, the night is over at this point. And so we really talk to patients about if you feel alert, feelings of alertness will come and go, it's okay. Effort, putting effort into sleeping, trying to sleep, isn't helpful because sleep is kind of an automatic process. If you try to put effort into doing it, it just doesn't work so well. People can have expectations about what sleep should be. They have judgments about their sleep, and then they can also monitor their alertness during the day too, right? And so if they have fatigue, there can be some anxiety and stress about that, whereas, many people are walking around sleep deprived and they usually don't think about it. They go to Starbucks or whatever, but people with insomnia will be thinking about that and kind of worried about it. So that's the cognitive therapy part of things. Just a little bit about the effectiveness. 26 to 43% achieve remission from insomnia. About 70 to 80% of patients benefit from it. In terms of medication, comparison with medication, there have been studies that have compared that and find that overall it's similar in effectiveness in the short run, and it can be more effective in the long run. I'm going to go through this a little quicker so we can get through it, but there have been lots of studies. There have been 9 meta-analyses, I think 10 now. One thing that you'll notice about CBTI is that the person won't really be sleeping longer, so that total sleep time doesn't always increase a whole lot with the treatment. But what we find is that over the course of 2 years with follow-up, people add on an additional 50 minutes to their sleep time. So it's a treatment where there can be, ongoing benefit as well. This looked at CBTI in populations that had fibromyalgia and had psychiatric issues, medical issues, and what they find, they're looking at remission of insomnia, and what they find is, just on this last column here, all of the studies show that the CBTI is favored more than the comparison group. So if you have a comparison group and you have the treatment group, the treatment is helpful regardless of all these different conditions. So we can use it in these populations. This is really an interesting study, and it's a Swedish study, and it looked at 43 people who were diagnosed with depression and insomnia, and they received either an internet-based CBTI program or they received an internet-based depression program, CBT program. And what they found, and then there was a 3-year follow-up after that, and they found that both groups showed significant improvement on both depression and insomnia. And they found that the insomnia treatment was better for insomnia, which makes sense, but they found that there was no significant difference in depression. So they found that even with the insomnia treatment only, depression was improved. They looked and followed up after 3 years, and they found that there were reductions in depression severity were similar in both groups, but with insomnia, the insomnia group had better control of insomnia and had less insomnia. So I find that really interesting. Just in August in the journal Sleep, there was another study that was kind of similar to this, looking at anxiety. And so it's very promising that it may be the idea of treating the insomnia can really help with a number of other conditions as well. So I'm going to go through this a little bit quicker. Let's see. So the American College of Physicians, the internal medicine group, does recommend CBT as a first-line treatment. And then if it isn't helpful, then there would be looking at decision-making around use of possible medications. There are some disadvantages, right? This is really hard work to do, and sometimes patients, that can be really difficult for them. If a person's under a lot of stress, it's really hard to do, so they might not be able to do that, or it might not be appropriate to do it. If anxiety is really high, that can be difficult for people. If they prefer not to do the sleep log, we try to modify it certainly, but that can be a little bit less effective, I would say. I wanted to talk briefly about one alternative, I guess you could say, to CBTI, which is sleep hygiene. And I think this can be very helpful, but there are some downsides. And this was noted by Don Posner, who is a behavioral sleep medicine person. And so he said that, well, there are some limitations with sleep hygiene. And again, this is what people read about in magazines. They're always reading about sleep hygiene, and almost to the point where it has like, these are the rules, these are the guidelines, this is what you have to do. Don Posner compares sleep hygiene to dental hygiene. He says, okay, these things are great. Just like with dental hygiene, you brush and you floss, and that's helpful. You need to do that. But if you have a cavity, then you need to go get that treated. And so for sleep hygiene, it may be a similar idea, right? That sleep hygiene might not actually treat a diagnosable insomnia disorder. Sometimes the guidelines aren't always true or helpful. People can say, oh, I have a wonderfully consistent schedule. I go to bed at the same time every night, no matter what. I wake up at the same time, but I still have insomnia. And as we know, as we've been talking about, it may be that they're sleeping 50% of that time. So they're following the guidelines, but they're not maybe helpful for them. So sleep hygiene is certainly best tailored to the individual if you use it. And providing a rationale for it is very helpful too. Sometimes people are like, well, I'm doing this because I'm supposed to do it. And they don't necessarily know why it is that they're doing it. Don Posner actually came up with some different ways, I think, to do sleep hygiene. And I think it's kind of interesting, so I wanted to show it to you. Let's see. The sleep slide isn't really advancing right now. So I'll just kind of describe what it is, and maybe you'll be able to see the slides at some point. But they break it down into lifestyle tips for those with good sleep. So they're saying, okay, if you have good sleep, then keep that circadian rhythm strong. So the two main things if you have good sleep already are you want to maintain good circadian health, right? You want the daytime to be filled with light and activity, the nighttime quiet, and with no activity. And you exercise at the same time of the day, eat meals at the same time of the day, and then also keep daytime and nighttime separate. So, day is for activity, night is for lack of activity. And so this is a little bit looser, right? It's more conceptual. It's based on working with your body. Let's see. Yeah, I don't know, the slides won't advance, but anyway, I know we're going to end in a minute here. But the other slide I was going to show you was then there was a separate set of recommendations if a person actually has poor sleep, right? Not insomnia, they would recommend treatment for insomnia. But if there's poor sleep, then there's a set of things to do. One is keep the same schedule, right? Don't compensate by going to bed later or not doing certain activities during the day. I need to rest, I'm not sleeping well, and then the circadian rhythm gets kind of off track. So these are kind of interesting ideas. So for sleeping poorly, don't compensate for a bad night's sleep, and do not spend excessive amounts of time awake in bed. So I did want to briefly discuss CBTI options for patients. And I guess the main thing I would say for this is, unfortunately, there aren't a lot of people that do this. I would be happy to help you if any of you are looking for CBTI people in your area. You can feel free to email me, and I can use my listserv to look into that and to try to find you someone. The pandemic is bad and good for this. It was bad in that now there's just a huge amount of people seeking mental health care and sleep care as well. And so the wait times have really increased for everybody. The good news is telehealth is being used. And there is something now for psychologists where it's called PsyPact. Psychologists can actually practice using telehealth outside of their jurisdiction. So if you're part of PsyPact, you can do telehealth with people in different states. Like I was able to find somebody for a patient who was actually from Pennsylvania, but who would do telehealth with a patient. So I can always help you with that. The Society for Behavioral Sleep Medicine has a directory. Go to Sleep is an online program. Once I turned in the slides, I did talk with a colleague, and they have a whole list of online and app-based programs that I can send to you if you'd like. Just feel free to email me about that. Somrist is prescription CBTI. I don't know if that makes much sense, but you actually do have to get a prescription to do it. It's an online program. And then I do have more information. If you're interested in pursuing behavioral sleep medicine, there are a number of resources too that I have in the slides, and I can always show you. There's a wonderful Society for Behavioral Sleep Medicine. There's a wonderful seminar too that the University of Arizona does. And I think it's every Thursday, or it might vary, but it has some wonderful presentations. So, thank you very much. I appreciate the opportunity to talk.
Should I see if we can get to
Can you just start advancing?
Yeah, oh, that's okay. Any questions there? Yeah.
What about reading in bed?
Reading in bed, yep. So,
Good or bad?
yeah, is reading in bed good or bad? I would say that it could be either, right? So that's usually not the first thing that I say, oh, don't read in bed. You can't do that, because that increases the anxiety. And some people find that really nice to do. So it wouldn't be the place where I would start with people, right? It's more important overall. If they're reading for an hour, then they're extending out that window of opportunity. So kind of being able to explain the rationale to that for patients. If they're reading,
Better to read somewhere else.
it could be better to read somewhere else. And people say, oh, I love reading in bed, then say, fine, read in bed, that's okay. Because what I find is balancing the acceptance idea as opposed to trying so hard to change can actually be good overall. Now, if you're doing a trial of CBTI where they're bringing in their window, then we might limit that, and we might say, find a really comfortable area to read. And then that it kind of limits that time in bed doing other things. Yeah.
Work with people that do want to change their rhythm and be early risers, and is that just all cognitive therapy pretty much as well?
Yeah, well, that's such a good question about, do people want to change their circadian rhythm? Like, let's say they're delayed. It's a balance, right? So I like to give the example of the kid in college. Do you sign up for the 8 o'clock class and then try to change your circadian rhythm by having a consistently wake up at 7 every day? That might be really hard to do. Or do you want to pick a later class? If people are wanting to shift, they do sometimes, and we do help them to do that. I try to steer them away from like getting up at 5 because that's almost in the morning lark category. But certainly we use light exposure. Light in the morning can pull in that circadian rhythm, so there's some ways to do that. Melatonin can be used. Melatonin is not such a good sleep medication for insomnia, but it does help sometimes to shift that circadian rhythm earlier. So.
Time for 2 more? Yeah, we have 2 from the Slido. One is, do you use actigraphy to complement or supplement sleep log data in your practice?
I don't use actigraphy, but I always say, oh, I'm going to get that actigraphy, and I haven't yet. But to be honest, with that sleep log data, and as you do this, you're seeing many sleep logs every day, and so it becomes something that you're used to kind of seeing, you're used to kind of being able to interpret it pretty well. So keep in mind, with insomnia, we're using a subjective assessment of it rather than, we're not always trying to look at how was the person's sleep exactly. We're really more looking at the person's perception of their sleep, and we find that that is acceptable and is okay and is helpful. They can have their insomnia treated by using their subjective opinion.
Thanks. And then last one, what patients are best suited for the app in your opinion?
Oh, I would say for the app, people who are a little more used to using technology, they're used to doing things like that where they follow instructions, and many people with insomnia are like that. They're a little bit, they're bright, they're conscientious, they work hard on things. The only downside is if they do have a lot of anxiety, then sometimes if they do that, they could do the app or they could do online. They might need to also work on the acceptance part of things. If they say, oh, I get out of bed every time if I'm not sleeping. Oh, I hate that. I hate doing that. Then we have to go with, okay, try now to just stay in bed for a while. So, yeah.
Very good.
And we do have your resources up here now.
Oh, great.
So,
well, thank you.
Anything else you wanted to say about that? Thank you, Dr. Loomis. And here's her contact information. Like, oops, like she said, if you have other questions, please reach out to her directly, and she'll be happy to help you.
Yeah.
Thank you for joining us again.
Oh, thank you. Thanks for having me.